Okay, this is chapter 4 for communication documentation. We're going to go through some of this a little bit quickly because it's very redundant. I also want to point out that communication tools and equipment are changing all the time. So what is seen in here might not be the most up-to-date for what you guys will find in the field. You also need to make sure that you are defaulting to any of your regional protocols or your agency protocols when it comes to documentation for patient care reports. But we'll go over the general parts and I'll show you guys some resources that you can look up when you get out in the field so that you can have it available to you to know where, know where to go for a basic understanding of things, at least in Southern Arizona. All right, so communication is a big part of what we do, both with our patients, with other care providers, like at the hospitals, and even with our own team members. Your nonverbal communication speaks volumes, and we need to make sure that we're aware of that. Nonverbal communication is a huge part of our job. Reading nonverbal communication from patients is also a huge part of our job. So being able to look at those clues that patients are giving you and also how your body language comes across. When you are communicating with somebody, your body language can diffuse a situation or it can make it worse. So start practicing nonverbal communication, start looking at how you talk or how your body talks when you're speaking to somebody else. All right, so other parts of nonverbal communication, you can use it to your advantage. So when somebody is, say, being very aggressive, your body language speaks volumes and it can diffuse the situation. I call it the hairy gorilla syndrome. When a bunch of people sit there and they want to be all tough on a scene, that can do nothing more than ignite the entire situation. But staying calm, having your body language very calm, but also being prepared to act is a big part of what we do. Same thing if you have a patient that's timid, your body language reads a lot before they even start communicating with you verbally. Everybody has a bubble. And we let certain people come closer to our bubble, and we want to keep distance for other people. So watch how your patient's communicating with their bubble. Are they protecting it, backing off? Are their hands here? These are signs that they're protecting their bubble, all right? Make sure that you're aware of those things and that you are not pushing your space into somebody else's bubble, all right? Physical factors that also affect our nonverbal communication, if there's background noises, cultural norms, actual language barriers that are perceived, those are other things that can be inhibit our communication, right? So cultural norms there's an assumption of a language barrier as well. So make sure that you kind of are doing your best to communicate in ways, even if you don't understand the culture, with respect to that culture. All right, questions. So when we ask questions, remember your open-ended questions and your closed-ended questions. Depending on how the patient's condition is, if I have a respiratory patient, I don't want to ask a whole lot of open-ended questions. I want my short, closed-ended questions first. Same thing if they have a complicated complaint or multiple complaints, I'm going to ask my closed-ended questions first. Open-ended questions allow you to gather a lot more information about what's going on. So with our open-ended questions, we can gauge our closed-ended questions. That makes sense. You want to be careful about asking open-ended questions because sometimes you can get a lot more information than you really need, and trying to redirect that patient back onto a task of what's going on is important. But making sure that you're also listening in a receptive way. So if they're just talking and you're not understanding or paying attention to what they're saying, that comes across a lot like you don't care. So we need to make sure that when you ask a question, you're actually listening to an answer. I've learned that with kids, they'll say something, I'm like, what did you just ask me? I've learned not to unilaterally say yes to things for the same reason, and they're good about coming in while I'm already distracted. So distractions on the scene for everybody makes it harder to communicate with your patient, all right? When you ask those open-ended questions, take notes, so that you can narrow down, your complaint with your assessment of what's going on, right? We call it history of present illness. That means what's going on right now with your patient, what their current complaint is. That is where we can gauge, what's going on today. Why did you call 911? That's an open-ended question. From those, we can start narrowing down with our closed-ended questions and figure out what's going on. All right. So different types of tools. Reflection is one of the ones. Okay, I understand you're having chest pain. When did this start? After they're telling you, make sure that you're repeating things so that they understand and that you're reinforcing that you know what's going on with your patient as well. All right. Explaining what we're doing is important, again, to gain consent. Clarifying what you're saying. Don't use medical terminology around patients to try and sound smart. You want to make sure you're speaking in clear, easy language to understand. Right? We are interviewers, we're detectives, so we have to get a whole story. So make sure that you are using good interviewing techniques, and that's something that only comes with good practice. So be practicing on your family members, be practicing on your fellow students, when you're interviewing them and asking them what's going on. You want to be able to fine tune those skills. And realistically, those are things that you're always practicing for the rest of your career, is how you're going to fine tune your interview skills. Right? So things to avoid: false assurance and reassurance. Those are things you don't want to give people false hope in situations. Unsolicited advice. Also remember that we are not licensed healthcare providers, so you have to go off of what your protocols are and what the medical direction is going to allow you to do or not do. All right. And then, the big one, speaking professional jargon. Those are things that can lead you down a dark path as far as you're trying to sound smart, but it leads to communication issues, it leads to confusion, and that can lead to problems with consent later on. All right, so friends, family, and bystanders. Bystanders and family can hinder an interview process, or they can help. Sometimes if a patient is not being allowed to get 2 or 3 words in because of bystanders or family members, I'll ask my partner to go, hey, can you take them to go get a medical history or go see if we can get medications list? And that allows me time to communicate with just the patient. With pediatric patients, make sure that you're talking to the caregivers as well, but don't forget to talk to the patient. Regardless of how old you are, there's nothing more annoying than having somebody not speak to you, but be speaking about you while you're sitting right there. All right, so eye contact is important. It talks about the golden rule of maintaining eye contact. I can tell you that some situations call for you not to maintain eye contact, especially people with spectrum issues. People with spectrum issues will not necessarily want to maintain eye contact with you. So make sure that you're aware of those, again, with their bubble, okay? I always use their proper names, Mr. and Mrs., when I'm talking to other adults. With kids, I don't talk down to kids. Make sure that you're using their name though. Find a common ground that you guys can kind of establish that rapport with, all right? Make sure that you're maintaining your HIPAA, within your HIPAA protocols and within the HIPAA guidelines, even when you're talking to other family members. Sometimes neighbors will show up on scenes, things like that. So you can't necessarily go around saying, hey, this is what's wrong with this patient. They can ask the patient if the patient's there and able to talk or stable, but for the most part, we have to really, really be careful about HIPAA, okay? Slow, clear, and distinct language. I have a hard time because I speed through things when I'm speaking. So those are things that we need to make sure I have to be very aware of, how my pattern of speech is. Am I speaking clearly? Am I speaking loud enough? Am I speaking slow enough, all right? Always allow people time to answer. The older we get, we tend to take more time to answer questions. Don't assume that it's because they don't know the answer to that question, but allow them time to think about the question. And again, keeping the background noises limited. That's a big part of it. One person interviewing the patient. When everybody's kind of jumping in with questions for this patient, that can be distracting. Even when you have somebody working on vital signs on a patient while another person's talking to them, that can be a distraction for anybody. So limit the background noises and the distractions best you can, all right? If somebody is, and this talked about older patients, if you encounter hostility, it can be any patient, all right? Don't assume it's normal. Don't assume that's their baseline. Remember, baseline is alert-oriented times 4, the GCS of 15, unless otherwise shown, okay? Make sure that you are respecting the bubble, maintaining your own safety. Just because somebody's a geriatric patient doesn't mean that it's not, or that it's a safe environment for you to be in, all right? And then with any patient, again, I want to avoid the ageism in this. Look out for signs of confusion. that they're anxious, impaired vision, you've got to watch that patient's body language, okay? So when we get older, remember that our nervous system breaks down a little bit, so we need to be aware of that sense to pain, right? So make sure that we're doing a good assessment on our patient. There's also fear of going to hospitals, fear of having a complicated medical issue, denial, those sorts of things. So make sure you're doing a good, respectful assessment of your patients. Be aware of changes, and then be aware of how their communication, if they have things like hearing aids offered, take those with you. Make sure you're taking the right hearing aids, glasses, things like that. Those allow for the continuation of communication. And that rapport is just really, really important. Build that rapport with your patient. Even in a couple minute setting, you can still assess your patient while building a rapport with them. All right. All right, packing personal items before you leave for the hospital. I'm really, really cautious about letting patients take personal items to the hospital. I kind of make sure that they know, you don't want them taking lots of money to the hospital. They're going to need their insurance card, their ID, those sorts of things. But the big ones are hearing aids, dentures, glasses. With children, it is, maybe a stuffed animal or something they love. But you don't want to take a whole lot of personal items with you, because those are all things that could be lost. Last thing when I document is also patients' personal items with patient at bedside. And if there was something that was not a normal item, like a walker, a wheelchair, something that belonged to them, I also state that that item was with them, and I make sure that item's with them at the time of patient transfer. And I state it in my documentation as well, so that it's noted these items were with that patient, and they were with that patient during the entire care that we provided, and that we responsibly turned those patients' items over when we transferred patient care. All right, children again. Some kids are afraid of the ambulance, the uniform. If you're shorter and you've got all these people gathered and hunched over you, that's a big deal. So get down on a patient's level, get on your knees, communicate with them the best you can to alleviate some of the fear. If they're stable enough, you allow them to maybe use your stethoscope, or ask them which they want done first, pulse ox or blood pressure. I don't really say, can I do your blood pressure? Because if they say no, I've just kind of hosed myself on that, right? So I ask them, which one do you want to do first? All right. Things to take with them, again, a doll or blanket. Those are important things. I really don't like having the plugs, the pacifiers in their mouth, because that's an airway issue. That talks about letting the patient's parent, guardian hold them during the evaluation. Again, that depends on the severity of what's going on with that patient. Sometimes parents can make it worse. If the parent's freaking out, the child's going to freak out, right? So being able to deal with those situations and diffuse them are very, very important. When we transport the patient, do not transport the patient in the parent's arms on the gurney. That's incredibly dangerous. In some agencies, it's actually not even allowed. If the parent has to ride in the back of the ambulance, I prefer parents to be up front and buckled into the seat, because that's the safest place for them to be. If they have to ride in the back, they need to be seat belted in. The airway seat, which sits right behind the gurney, is the second safest place in the back of the ambulance. The first place is buckled into the gurney with all of the right straps in the right place. I want my partner to be able to have that airway seat as a place for them to sit and retreat to if it's necessary. The bench seat also has seatbelts on it if needed, but remember the impacts that can occur during a collision, so it can cause trauma to their body. I'm always worried about people that I take as a rider, because that's an added responsibility for their own safety, or for their safety as well. When you're communicating with kids, make sure you're honest with them. You don't want to burn bridges for yourself, but also for other healthcare providers coming afterwards. Kids will see right through you the minute that you're not being honest with them, right? So eye contact, make sure you're getting down to that child's level. Remember that we have the implied consent laws for kids with their caregivers, or minors that don't have their parent or guardian on scene with them for life-threatening emergencies, right? But communicating with them, telling them what you're going to do, don't talk down to them. Those are all real important things. A lot of people are nervous when they have to deal with kids. It takes practice when you have a pediatric patient. And the best thing you can do is just practice that, right? Find opportunities to interact with children if you don't normally have those opportunities. and fine tune it just like you would with any other patient interview technique. All right, hearing impaired patients. A lot of patients can read lips. It's harder now because we have to wear masks all the time. So those can be barriers to communication. Somebody who can't hear, you can have a pad of paper. I always have extra paper with me and a Sharpie so that they can write out messages. It talks about, your book talks about knowing simple sign language. Be very careful about that though, because if your signing is not appropriate or you're not communicating appropriately, again, that can be a whole legal issue later on. Making sure you have hearing aids if that patient has hearing aids available. Is it turned on? Can they hear it? I've also had people grab the wrong hearing aids. They've grabbed their significant other's hearing aids and try to take those to the hospital. So those are important things that we need to ask, right? Yelling at a person who's hearing impaired does nothing, all right? Minimizing background noises helps a lot. So keeping those things in mind when you're dealing and talking with somebody who's hearing impaired, but you can always default to pen and paper. All right, so this is where it talks about, simple sign language. Again, be very careful about what you're using for sign language. If you do not truly know what you're signing, don't do it because it presents a legal issue with consent later on. All right, visually impaired patients, people who can't see or have partial visual impairments, make sure you're communicating with them. Tell them that you're going to do something before you do it, which you should do with any patient, but don't just grab their arm and start helping them move. Make sure that you're communicating what you need to do, where things are in position. If you're moving furniture inside their house to get a gurney in or out or move them in or out, make sure the furniture gets moved back to the place where it needed to be. That's a really important thing to think about. All right, and then when you get them in the back of the ambulance, make sure they know where you are in relationship to where they are sitting in the ambulance. Any sort of assistive devices should be taken with you to the hospital. People ask about pets. So if they are therapy pets, trained pets, CNI dogs, those sorts of things, do we take them with us to the hospital? I am very leery about it. We can't refuse it. So Americans with Disability Act says we can't refuse it. Now, animals can act strangely when their caregivers are in distress. So I'm a big dog person, but I don't necessarily want a dog I don't know in the back of my ambulance with me if something happens with their person. I tend to ask, what is the plan put in place for your animal if you had an emergency? So people that are given animals or have trained animals for therapeutic reasons, there's usually a plan in place if something happens and there's an emergency with that person, so that can be activated. Just make sure you're treading those waters carefully. All right. Again, we just hit that. So who can take care of the dog? Who's in charge of taking care of that animal? Just be aware, though, that dogs, especially, but any animal, can act. A normally calm dog can act aggressively or act strangely when their person is, in distress. And that's just something I can't even harp on enough. You want to be very, very careful. The other part is having an unrestrained animal in the back of an ambulance presents a hazard for a lot of reasons. And it's a hazard for the animal itself. All right. So when there's a language barrier, use short questions. Close-ended questions work a little bit better. The best you can do is for a patient who has a life threat, you shouldn't need to be able to communicate in their language to truly determine that life threat. You should be able to do your assessment through your primary assessment and figure that out. Gaining consent's a big one. So there's nonverbal signs that somebody's refusing consent, just like there's verbal signs that somebody's agreeing to consent. So you need to be aware of that because you can get in a lot of trouble even if there's a language barrier, right? Also, during your documentation, it's real important to put that there was a language barrier during the assessment. If a family member or friend's interpreting, make sure you document that as well, that you were not the one trying to interpret, that it was coming secondhand from a family member, right? There are little flip books that you can learn basic medical terminology in different languages. So knowing what languages in the area, obviously Southern Arizona Spanish is the biggest one. when you get to the hospital, when you're transferring care, or when you're relaying your telemetry to the hospital, make sure you let them know that the patient is Spanish speaking only. There's a language barrier of some sort, even or a visual barrier or a hearing barrier. All those things are important to communicate to the hospital so that they can be prepared for it as well. All right, interacting with other healthcare professionals, that's a big one. So our body language also feeds to other healthcare professionals. We're having a stressed out day, if we're tired, if they're tired, it can come off the wrong way and create some friction between. Our job is to communicate that story of what we did and transfer that information to whoever is taking patient care. Now, we need to make sure that we're only handing off patient care to people who are at our certification level or higher. Most hospitals, though, have it in their protocols that only certain people can take patient care and take report. So make sure you know those. Most people, though, if they're in there and they're a tech and they're not allowed to take patient care or patient report, they'll say as much. So communicating what's going on with your patient, painting the picture of everything that's happened, make sure you're doing that in the best way you can possible. Now, over the telemetry, we give a brief snapshot of what's going on over the radio. When we're in person, though, those are where we can get into the details, right? My radio report needs to be real short, concise. I can't discuss HIPAA information over the radio, but when I get in person, we can get into a lot more detailed of what's going on with that patient. It's more than the snapshot, and that's information we need to relay for the continuation of care. All right, so again, we're going back down. Different hospitals have different papers that they need to fill out, and everything kind of goes in a specific order. So when you start giving your patient care reports at different hospitals, you'll learn very quickly what order they want their report given in. There's basic components to the report. You're basically saying the patient's name, their age, their chief complaint, what you found upon your assessment, the history of present illness, your interventions, your vital signs, the results of your interventions, right? Usually with vital signs, we only give them the most current vital sign unless something was really, really off when we first initiated patient care. After that point, what changed in their vital signs. Those are things that you point out to them. But for the most part, it's just going to be the most recent set of vitals. All right, written communication documentation. So patient care reports. There are so many issues with patient care reports. We tend to just get complacent when we do our patient care reports, but they provide a lot of useful information. For one, is the continuation of patient care, which is a legal document that shows what you did during your job. So if something goes to court, you have that to kind of back yourself with, all right? It is the story of your entire patient contact with that patient from the moment you were dispatched to transfer patient care at the hospital. When we are going through patient care reports and looking, base hospitals are looking at, educators are looking for things that maybe need to be educated a little bit better on. Maybe there's best practices in play, and so they're pulling out information and data to help train other healthcare providers. We're also pulling out data for things like drownings, heart attacks, pre-hospital CPR initiation. So all of that stuff is provided in your patient care report, which is why it's really important that we document honestly, we document thoroughly, and that we consistently document the same with our different reports from patient to patient. Those are all things that are looked at legally when we go to court. Now, there's other parts of the patient care report, like your billing. So billing, people tend to say, oh, I don't care as much about billing. They don't really go through it, but that's how we get paid at the end of the day. That's how tax-based organizations know how much, if they need to raise the taxes in different districts. It's how you get new equipment. So billing is just as important as the rest of the patient care report. Your book talks about the different types of patient care reports. There's written and electronic. It's very rare to find written patient care reports anymore. The state of Arizona has gone to an electronic reporting system, mandatory electronic reporting system. Very easy to extrapolate information out of it. But we need to make sure with either type of report that we are presenting ourselves as a competent provider. So back in chapter 3, we're talking about, if your report looks sloppy, it's assumed that you're a sloppy provider, all right? PCRs, the functions of the PCR, again, continuation of care, documentation, education, the administrative information, like billing, right? The recent research record, and then the CQI, so continuous quality improvement. All right, so we have documentation standards. Your book kind of vaguely explains it. I'll show you guys in a minute what the Southern Arizona region uses for a documentation protocol and standard. So basically any electronic documentation that we have or any form of documentation still has to hit on all of these parts to be legal in this area, in this region. All right, so it goes through, again, from dispatch to transfer patient care, and it tells a story. This is kind of a drop-down box. It shows a different type of form. Different agencies use different platforms for their documentation. There's Zoll, there's Meds. I mean, there's a whole bunch of PCR reporting platforms. The kind of cool part about the electronic reporting is that it has the drop-downs. We can fill in a lot of our patient assessment in the drop-downs, and then our narrative kind of fills in the blanks of that, fills in the missing pieces. The problem with electronic reporting is that you can also make mistakes. So if you have to document vital signs in one place and then you're trying to write them down in your narrative, you have to be careful and make sure that that we're documenting the same information. Because if you're duplicating information, there's a good chance that you could make a mistake in that. And then spelling matters, regardless if it's in paper documentation or if it's in your electronic documentation. You need to be able to spell, and not every one of them has spell check on it. So we need to make sure, again, that competent part of the patient care was delivered. All right, so narrative section, that's where we write the paragraph out, all right, where we're explaining what happened, we're painting that picture. It's really important that we have a clear, concise pattern to our documentation. If we go to court later on, it's not going to be the next day or the next week. It could be a year later. We might not remember the details. So our narrative helps us fill in the blanks and reminds us of the details of that call. They will also commonly pull documentation from other patient care. They'll wipe out the HIPAA information to see if you were consistent in providing your patient care to this patient from one patient to another. All right, pertinent negatives in the narrative. So pertinent negative means that you check something, like say they're having abdominal pain. Does it hurt when I push down? No, that's a pertinent negative, right? Does it hurt when I let go? Yes, that's a positive finding, right? You'll find on your test the term pertinent negatives pops up again. So be aware, pertinent negative is something that you did assess, all right? But your findings were negative. All right. This talks about reporting errors on paper documentation. It talks about you just draw a line through it and initial. If you have to do an addendum on a electronic documentation, there's a process in place for the addendum to be filed in your documentation and attaches to the PCR. Make sure you're following the appropriate protocols for the addendum, all right? Never falsify any information. Don't say that you did something that you didn't actually do. You can get in a lot of trouble for that, but it's also poor patient care. Don't try and cover over erases or erase things with pen or try and scratch stuff out completely on a paper PCR. You signal line and initial it, all right, when you go through it and you're trying to fix that error. Same thing with a addendum that you're doing. Make sure that you're consistent and not making errors when you're duplicating information. That's really important. All right, refusal of care. This is back to chapter 3's information. Make sure you need to carefully document refusals of care. That is something that every agency has a refusal of care form. Make sure that you're having somebody witness that if it's possible. And if possible, get somebody that's not your partner. Remember, your partner is probably the worst person to witness on a documentation for a refusal. And then make sure you're completing that PCR. If the patient can sign and is willing to sign, their signature is very valuable on that, showing that they understood that they are refusing patient care. All right. Special reporting situations, we have a lot. It varies from actually county to county and state to state. But again, we're mandatory reporters for the suspicion of sexual assault. Something that is occurring during a crime, so gunshot wounds, obviously. I'd love to think that police are on scene for every one of those, but again, we have to report those. Dog bites have to be reported to either law, in Pima County especially, but in Arizona, to the law enforcement agency that's responsible for the area in which the dog bite occurred, or animal control, depending on the time of day and what's going on. We have to report all dog bites. All right, radio and telephone communications. So we use radios and we use phones to communicate back and forth. We know that, right? We get dispatched on a radio. We actually use computers now for dispatching. And then the telephone we use as a backup. Everything you do is recorded, and that's important to remember. From every keystroke on a computer to everything you say on a radio or a telephone that is linked into any of our communication centers or linked to a hospital. So make sure you're aware of that when you're speaking or when you're typing. All of that's recorded and can be pulled up later on. When we have communication systems, well, let's start with during 9/11, we found out that communication was our biggest, one of our biggest downfalls. We couldn't talk to other agencies. So post 9/11, we've come up with radios that can talk to different agencies. We can talk to law enforcement. We can switch bands back and forth. We have a mutual aid kind of frequency that we can talk to when there's all sorts of things going on. That's very important because being able to communicate as a group and have that kind of incident command structure where we can have the incident commander and know what's going on with the different parts of this entire incident is very, very important. All right, so base station radios, this is a transmitter, all right, and it's a fixed location, so like a comm center. Right. Two-way radios, we have the handheld radios. We have radios in the truck, so a transmitter and a receiver. The more mobile and portable radios, again, mobile is in the truck and portable is the handhelds, okay? You shouldn't be leaving your truck without a handheld on you, right? You also use it as a backup. So if our mobile radio goes out in the truck, we have our handheld radio, right? And the batteries have to be charged. Just like with an AED, it's on us and we're responsible if they're not charged. So you tend to have multiple frequencies or even two radios in the ambulance on the mobile radios for different trunk systems. And then your portable, hopefully you have two, but you have at least one that you take with you when you leave the truck. That's your lifeline. So making sure that you have your radio and it works when you go into a scene is very important. Now there are areas that are dead zones for the radios, especially here where we've got things that are very, very rural in areas. That's why we have offline protocols that we can run off of, is when the radios aren't working, we can default to our offline protocols. We also have the dispatch computers, but again, computers can go down. That gives us information. We can look up maps, right? We get a little bit more detailed information about what's going on with the patient sometimes than they're able to broadcast over the radio because of either HIPAA issues or they just don't want to broadcast all this information out. They want to keep their radio transmissions nice and short so they can put more of it into the computer system. Some agencies still have pagers. We can get a pager, our page with a digital readout of what's going on or notifications if there's something going on that they don't want to broadcast over a radio as well. We'll get it on a digital. It's important to remember also that people like news agencies can access our radios and listen in on them. Even with our trunk systems, they're still able to listen onto these things. So being aware of what you're saying on the radio is very, very important because you don't want to put a scene at risk because you said something that shouldn't have been broadcast over a radio. That's why we have the computers and why we have the digitals. All right. So portable radios, handheld devices, all right. It's our lifeline. It allows us to communicate with various people. We can switch the channels on it, frequencies. If we end up in danger, we can broadcast that from our portable radio as well. So having your radio and having it charged is a safety issue. All right. There are repeater-based systems. So we use a trunk system in the Southern Arizona region. Some departments are still on the older bandwidth stations that need repeaters that bounce off of different, when you have a blind spot or you need to go from mountain to mountain, there's a repeater. And then some ambulances actually have mobile repeaters in them as well for more rural areas. So it allows the ambulance itself, the mobile radios, and turn the repeater on to become a repeater station to allow the signal to bounce out of the dead areas. A lot of this stuff, can be, some of it's outdated. A lot of it is more detailed than what we get into with this class. So understand that we now have a lot of advancements in the mobile communications. Right now, most of our mobile communications run off of cell towers. They get priority frequency on cell towers. The biggest problem, so instead of just having a radio tower like shown in this picture, we have a cell tower that we're able to use just like with your cell phone. Problem is when cell towers go down, the system goes down. So having backup systems in place is really important. We have cell phones for the units, that's important as well. We also get dispatch information sometimes on our cell phones. But what are we going to do if the cell phone towers go down? What are we going to do if we're in a dead zone and we can't get our radio to work? Have a plan. What are you going to do? You need to have a plan for safety, and you need to have a plan for patient, communication of how your patient's doing, to call for help, additional resources, things like that. All right. Okay. So digital equipment we use has come a long way. We have a telemetry process. We do a lot of relays now where we're just pinging off basically meds control, which is an operator, for lack of a better word for it. Meds control is an intermediary. So we contact them and they link us to the hospitals that we need to go to. All right. It's kind of like when you think in your head, the old switchboards that you see in movies. Or we can just say, hey, let the hospital know that we're coming in with this patient. When we want medical control, right, we need to call meds control and then switch to the hospital. Ask them that you need to go to whatever hospital that your medical control runs out of or that you're transporting a patient to. And that's where we get our online medical direction. We can also transmit EKGs now. We used to be able to, it was like an old phone system. You had to hook into a phone line to transmit it. Now we can Bluetooth it from our monitor. It can go through the cell frequencies and it goes to the hospital. So technology's come a long way. All right. And then they talk about satellite phones. Helicopters use satellite phones now. That's probably the only thing I can think of where they're using satellite phones. Helicopters have a lot of communication equipment, and satellite phone is one of those pieces of communication equipment if they need to call a hospital. But they also have the radios. They can do telemetries. They can relay. They can contact us on the ground depending on what channel their frequencies or what channel they switch to. So there's a lot of different ways we can communicate, but they still use the satellite phones on the helicopters. Again, we have to be very careful anytime we're using a cell phone or we're using an older portable radio. People can have scanners and they can hear what's going on. So we never transmit HIPAA information over a radio. Name, their age, what's going on with them, or their name, we transmit their age, but their name, specific things about what's going on with them, specific precautions, things like that. You don't transmit names and the specifics, including the name, over the radio. Same thing goes now when we're talking about HIPAA issues as Facebook, social media. You also have to be very, very careful because people want to post about this cool call they had and they want to post it on social media. You end up with HIPAA violations because everybody can see it. So we have to tread a very careful water with however we're transferring information. All right, so this is again kind of old, the simplex, duplex, and multiplex. So push to talk, release to listen is a simplex. Duplex is the talk and listen at the same time. These are the old kind of when you think about walkie-talkies. And then multiplex is 2 more frequencies, be able to switch channels. A lot of dispatch centers, they use the multiplex system. Right now, though, we use a trunked system in most of Southern Arizona. It's like standing in line at a bank and you go up to whichever teller's next. The trunk system lets us bump up on a frequency, right? So we don't have to wait for other people to clear channels. We bump up on a frequency of whoever's next. The FCC regulates what channels and frequencies we're allowed to use, and the ones that we use are reserved specifically for first responders. So we don't have to deal with, cell frequencies that are for the public, all right? So these are all regulated, and say every year we have to get a license for it. Your agency gets a license for it and renews it, and you can put that license into jeopardy if you're transmitting things or saying things on the radio that you shouldn't be. Okay, so trunking system, again, this is the latest technology. It is useful when it works. It is a nightmare when things go down. We have backup systems in place. We can always pull up the old simplex or duplex radios and move on to that. We also, in our ambulances, most agencies still have at least one radio that can work on that system, so that if the trunk system goes down, we can go to the repeater-based system. All right, talked about FCC already. Dispatcher, we refer to these guys lovingly as commies. They are the first step, right? So if somebody calls them, they triage what's going on, and then they determine what resources should be sent. They're also our lifeline. So they're the ones who, if we're in trouble, we have to get a hold of them, and they send resources or help us, when we have an emergency. So making sure you have a good rapport with your dispatcher is a really important thing. Make sure that they know where you're at all times. Now, most units have GPS tracking systems on them, so that they can look at a computer and tell where your unit is, or in relative proximity to where your unit is. And that's useful because it also lets them send out the closest, most available unit to a call when you're dispatched, right? Based on what their computer is showing them. So making sure that you are upfront about where you're at is really important, because you can, if you were the closest one to a call and you didn't tell them where you were, and you see another unit go flying by, one, that's going to cause a lot of problems. You're going to make some people angry. But two, you were not acting appropriately in a professional manner, and you are a closer unit to that person's emergency. Dispatchers are usually certified in emergency dispatching. That some places you even have to be an EMT at a minimum to be a dispatcher. They start going through and giving initial, instructions for initial care on the telephone while we're en route to the call, right? So they're multitasking all over the place. They're talking to a 911, they're typing in the computer, and they're talking to us on the radio to give us updates as to what's going on. All right, we also tell the dispatcher, anything that's going on while we're on our way there. If we have a delay to the scene, we make sure that we tell them when we're on scene. That's important. Make sure we're telling them when we cleared the scene, or when we're transporting to the hospital, what hospital we're planning on going to. Tell them when you arrive at the hospital and when you clear the hospital. Important things that you need to know. Those are also times that are mandatorily put into your documentation as part of your patient care, right? So it shows that you were consistent. It shows any delays in patient care, arrival at the scene. It shows if, if you have a legal issue. It shows that, hey, if you have to stop at railroad tracks and you're transporting a minor, and there was a delay in that care, they know why there was, or a delay in that transport, they know why there was a delay in that transport. So it's a lot of CYA as well. Okay, medical control. Again, we call it meds control, but basically they're an operator, an intermediary. We relay information to them, and they can transmit it to the hospital. But we also can get a channel to a hospital to talk to our medical control, talk to somebody who gives us the direction of what to do, all right? So we talk about medical control a lot, but understand that medical control is not meds control that we're calling. Meds control is an operator. Medical control, medical direction, online medical direction comes from your base hospital. It can also come from the hospital that you're sending your patient or taking your patient to when you need to give a report and ask them for permission to do something. So those are things we need to make sure we're clarifying, all right? But your medical control is through the physician under whose license you're working. All right, patient care report when you guys are delivering one. So when you get on, do a telemetry or a relay, this is Meds 813 transporting a 23-year-old female. She complained of abdominal pain. We have an approximate ETA of 20 minutes to your facility. Patient stable at this time. All vital signs are within normal limits. That's all we need to say, all right? If we're talking to somebody and actually talking to the hospital, we add in there, do you have any questions or orders? And then you document who you talk to. Part of your patient care report is documenting your relay or your telemetry, what hospital you talk to, and the person at the other end of it. Right? Okay, patient care report. Everybody does this a little bit differently. When we get into the classroom setting, we'll give you several examples of patient care reports. If you look at your medical assessment, the last step in your medical assessment is giving patient care report to whoever the provider that's accepting that patient is. Everybody does it a little bit differently, but it has the same basic information in it. We already talked about that with the verbal communication, all right? So I'm not going to go into it in depth here. We'll talk about it in classroom. We'll draw it up on the board because it's an important part of your medical assessment, all right? Medical control, this is again, medical direction. This is chapter 3 from medical legal, all right? We have online medical direction. We have things that we're allowed to do within our protocols and scope, and then things that we can assist our patients with. So those are things that we need to make sure we're very aware of with our agency and with our region, but also that you're documenting. And we're documenting what medical control, what protocol we're going on, online, offline medical direction, those sorts of things. That's an important part of our documentation. All right. Calling medical control, I've already talked about this, all right? When you call the hospitals and you want to talk to an actual person, sometimes it's a nurse who relays information to the doctor and then they come back to you. Some hospitals, you're actually talking to the doctor, the physician at the desk themselves. It totally depends on the facility. All right, some nurses, they have the protocols already written in front of them, so they know what they're allowed to tell us we can and can't do. If it's something really funky or weird, they'll check with the doctor and then they'll talk to us again. So sometimes it's not the fastest process, which is why we do relays. It's also why we have offline pre-contact stabilization orders in Southern Arizona. So things like putting our patient on oxygen, using our AED, those are things that we don't have to ask permission for. It's part of our standards of care. In the old days, we did have to ask permission to start CPR. We had to ask permission to defibrillate our patients. We don't have to do that anymore. All right. All right, special situations, we also need to communicate with dispatchers if it's a hazardous material situation that they weren't aware of when they dispatched us. If there's rescues in progress, multiple casualty incidents, if we're first on scene, we need to paint a picture of what's going on, not only so the dispatcher can relay it, but for any other incoming units that are listening to the radio traffic, because they should be listening to that frequency as well while they're responding. So we're painting a picture of what's going on when they get on that scene so that they're prepared for it as well. Right? Nobody wants to walk into a scene that they're not prepared for. So first on scene, you're painting that picture, and it's really important that we're carefully painting that picture because we don't want anybody to get hurt. All right. So multiple casualty incidents, we'll talk about this more with Mod 6 because multiple casualty incidents is covered in Mod 6 with the incident command system. So we have in Southern Arizona an incident command system that runs between the agencies. There's also mutual aid that runs between the agencies in Southern Arizona. Again, we'll get into a lot more of that during Mod 6. Just understand that we need to make sure if we're first on scene, we're giving the best picture we can, all right? And that those scenes can be chaotic. So if you're first on scene and you're ready to get on the radio, calm down, check your voice, make sure you're talking slowly and you're talking clearly. It's not your emergency, so don't make it your emergency, and make sure that you're just communicating the best you can about that scene. And those are stressful situations, especially the first time you ever have to do it. The radio itself is terrifying when you're new. People get mic fright all the time when they're new. It's just something that you overcome after a while. It'll become just like talking on the phone or talking to your partner. You get used to communicating on it. And then keeping in mind that our radio, maintaining our radios is part of our truck check in the morning. You need to make sure your radios work because the day that you don't make sure they work is the day that something happens and you needed them, all right, more for your own safety than anything else. So batteries working in your portables, switching out the batteries when they get low, and then making sure that your truck radio is in good condition. All right, if it's not in good condition, you need to report that to your supervisor and it needs to go out of service for repair. And there are steps in place with agencies if the radios aren't working, how you take it out of service. All right. And that is all I have for your module or chapter 4. I do want to show you guys the Southern Arizona protocols for documentation. All right, so hopefully you guys are seeing the documentation because I'm not sure which one I switched it on. This is under the SEAMS website. So if you go to SEAMS, and this is a hyperlink in your D2L, you can go to SEAMS, it's seamscouncil.com, and you can pull up all of the protocols. So one of them is the documentation protocol. Let me make sure that I'm doing this one so you guys can see it. Pop it in here so you guys can see it when I flip it. So this shows what we have to have in our documentation standards. Now it's a very short one-page sheet that shows what we must have inside our documentation, but it covers all of our assessments. Right? The other part of this that we can look at is the SEAMS protocols for patient care assessment. Now this is a longer page and document, but it's just like going down your medical or your trauma assessment, right? All of these steps have to be covered and documented as part of our patient care assessment. And those are all found under the SEAMS protocol page, right? And the hyperlink for that is into your D2L shell on the right-hand side. The other thing I would recommend that you start looking at when you have time is go in and type in EMS documentations best practices. GEMS has a really good article about EMS documentation best practices that's out right now. I can put the hyperlink into D2L for you. But it talks about why it's important to document, all right? Why it's important to carefully document and consistently document, all right? So I'll put this hyperlink in there if you ever want to go read that article. But best practices are always changing with documentation. The basic principles of documentation, though, never change. So getting a good vibe and a good pattern to your documentation is important. Once you get your documentation down, it becomes easier, and you're able to just cookie cutter your, I don't want to say cookie cutter, but you're able to consistently apply your assessment documentation to every patient contact that you have. All right, so when we get into class, we'll show you guys some different types of reports. We'll write them on the board for you, just how we would give our report to our accepting care providers. That's your last step in your medical assessment. There's a reason why your medical assessment is 15 minutes long. It's important to give a good detailed report. The summary of this entire chapter is basically use your nonverbal skills, practice them, right? Watch other people's nonverbal skills. Make sure that you are communicating well with everybody, including other care providers and your dispatchers. You don't want to make a nurse angry. Some people are having bad days. Remember that it's just a bad day. You can diffuse the situation very easily by how you come across, and that you're documenting carefully and you're documenting consistently. That's the basic principle of this entire chapter. All right, good luck and see you.